Hello, and welcome to the first installment of Ask a Hand Surgeon. I'm Dr. Brian Pinsky of the Institute for Hand Surgery at the Long Island Plastic Surgical Group. And I'm here to talk about one of the most common hand conditions that I see in my office, which is carpal tunnel syndrome. Just a little background information on me. I received my medical degree from Case Western Reserve University in Cleveland, Ohio. I did a residency in plastic and reconstructive surgery at the Mount Sinai Hospital in New York, and followed that by a fellowship in hand and microsurgery at the UCLA Medical Center in Los Angeles. And I see a varied practice of complex hand and wrist injuries and peripheral nerve injuries, including very common nerve compression syndromes such as carpal tunnel. So in order to get started, I thought I would just give a brief overview of what carpal tunnel is, who gets it, how we diagnose it, and how to treat it, and what to expect, and then field any questions that anyone may have out there about either their experiences or any other issues that they might be having. So first of all, what is carpal tunnel syndrome? So this is a question that many people have. It's something it's an entity that's very common in the vernacular, and people sort of know that it exists, but don't really have a good handle on what it is. So basically, what carpal tunnel is, it's compression. It's symptoms related to compression of one of the main nerves of the hand, the median nerve at the wrist. So just a brief anatomy lesson. As the nerves leave the spinal cord and travel down that arm all the way through the wrist into the fingertips, as they travel down through, they will reach a point as they cross the wrist where they come through a very tight tunnel. As you can see from this diagram, these are the bones of the wrist at the bottom, and these are the thumb musculature as well. And this is called the transverse carpal ligament, or the tight ligament that runs as the roof over the carpal tunnel. And within the tunnel runs all the tendons that cause your fingers to bend, as well as the median nerve. The median nerve, which is pictured here in yellow. And what the median nerve does is it provides sensation to the thumb, index, middle, and half of the ring finger, as well as motor strength to the thumb musculature, which allows you to bring your thumb up into this position, what we call the abducted position. It brings your thumb out of the plane of the palm. So it was long recognized that there was some problem that existed that caused people to have numbness in their fingers, as well as ultimately develop weakness. And in about the mid-1800s, they realized that this is probably coming from the same origin or the same pathology, which is compression of the nerve at the wrist. And most commonly, this is related to swelling of the cover around these tendons, or what we call tenosynovitis. And that can happen for a multitude of reasons. There are certainly risk factors that make you at risk for developing carpal tunnel syndrome. These tend to be women more common than men, age, other lifestyle issues such as obesity, smoking, pregnancy, diabetes, and there are some other more obscure entities such as amyloidosis or other issues that can increase the risk for carpal tunnel, and then repetitive motion activities. And this is something I will touch on in a little bit. And essentially, so what most patients will experience is certainly the beginning of carpal tunnel is numbness, tingling, burning pains, pins and needles. The symptoms tend to be intermittent. They come and they go. Sometimes you'll experience them at certain parts of the day, mostly at night. So waking up from sleep at night with a burning pain or electric shock-like feelings is very, very common. And eventually, as the disease progresses, the symptoms may become permanent, where there's a baseline level of numbness that's always present. And people complain of weakness with issues such as opening doors, opening jars. They can't do buttons on clothing because you can't feel your fingertips, and things like this. And as the disease progresses, some of these things may become permanent. So that's a little bit overview of what it is. And and here's just an example of weakness. This is what we call thenar atrophy, or atrophy of the thumb muscles that can occur, which I would call something of an end-stage carpal tunnel. Someone who's had severe disease for quite a long time, this is what can happen, and this is what we want to try to avoid by recognizing and treating the problem before any of these issues that are irreversible will set in. So that we've talked a little bit about what it is and who gets it, And then the answer is when to see a doctor is another question. Well, when should I address this? I might have a bias in this issue, but I would say very soon. If you experience these symptoms, a lot of, especially in the early stages, they are somewhat reversible or modifiable to prevent the disease from progressing. And certainly if you've gotten to the point where you would consider the disease to be moderate or severe, then it's certainly something that should be treated. So what is a diagnosis and how do we diagnose it? Basically, it's a clinical... Everyone agrees that there's a lot about carpal tunnel that the people don't agree upon, but everyone agrees that it is a clinical diagnosis. I would take a detailed history about your symptoms, how long it's been going on for, what kind of work do you do, what makes it worse, what makes it better, and then ultimately do a physical exam. And usually between history and physical exam, I'm able to diagnose a vast majority of patients with carpal tunnel. More often than not, either patients have seen another practitioner first, such as a neurologist or a primary care physician, and tests such as what's called determined to be a nerve conduction study is often ordered, which is a study performed by neurologists, which actually tests the function of the nerves, the electrical functioning of the nerves, and gives some objective measurements as to the function of the nerve. But in the end of the day, it is really still a clinical diagnosis. And other issues which can put people at risk are occupation related, so people with heavy vibrational activity such as jackhammers or construction, people that do forceful repetitive motions such as factories, assembly line workers, forklift operators, these kind of things. That there's pretty universal acceptance that these put you at increased risk for developing carpal tunnel. However, and one other question that is often asked is, well, I have an office-related job, I type on a computer, does this cause my carpal tunnel? And this is something that is not universally agreed upon, certainly in the literature. There are some studies with, say, moderate to low quality evidence that do suggest an association, and that is usually with people that type consistently for up to 8 hours a day, but average computer use has really not been shown conclusively to be part of a risk for developing carpal tunnel syndrome. And this is a little bit where it blends a little bit between the medical and the medical legal as people trying to, with issues with workers' compensation. But that's maybe beyond the scope of this of our little talk here. So what do we do when we treat it? So once carpal tunnel's been diagnosed and recognized, as with anything, depending on the severity, I will usually try some non-surgical treatment first. And this tends to be activity-related, activity modifications. So there are certain positions, such as a flexed wrist, or a patient with an extended wrist and pressure over the area, which can increase or exacerbate the symptoms. So many people will say, when I'm driving, I'm holding the steering wheel, and my hands go numb. Or if I ride a motorcycle, after 15 minutes, the hands go numb. So the simple answer is to try to avoid those activities as much as possible. Sleeping is often a culprit, as people sleep with their wrists curled up in a bad position. So often we'll recommend sleeping with splints at night, and these are usually store-bought splints that are inexpensive and an easy way to try to modify the symptoms. And especially those people with nocturnal symptoms at night will often experience relief. The next level up in terms of intervention would be a cortisone injection in the wrist, and this has been shown to at least temporarily resolve symptoms for up to, say, 6 months to a year. And then it also has been shown to be one of the best predictors for surgical success. So those that respond well to a cortisone injection will ultimately do well with surgery. And then finally, the treatment would be surgical, which would be a release of the carpal tunnel, which, going back to our initial diagram here, would be actually opening up this thick ligament that overlies the carpal tunnel, and that takes the pressure off the nerve. So when there's pressure inside, it decreases the blood flow to the nerve, and ultimately it makes the nerve not conduct the signal properly and not work properly. And if that happens long-standing over time, that's when you start getting the numbness and the atrophy of the muscles that is irreversible. So it's a relatively simple procedure, straightforward. It takes about 15 to 20 minutes in an operating room. Afterwards, my patients get a simple soft dressing and able to use their hand for basic daily activities, even the day of or the day following surgery, and then allow them to progress and increase their activity level as tolerated from there on. There's some small amount of sutures that need to be removed at about 2 weeks after surgery. Most people will experience mild soreness in the area of the incision for up to 2 to 3 weeks after surgery, and then are back to most activities. Those that do heavy labor, such as construction or other issues, may have some soreness swinging a hammer for a few months, but that's also expected, and it will resolve. I personally, in my practice, use an open carpal tunnel release. I think it's a safer, more accurate operation. There are other surgeons that do use an endoscopic technique, which is also very accepted standard of care. Just a small word about that is there's been no long-term difference between the outcomes between an open and an endoscopic release. Endoscopic patients can experience slightly less discomfort in the first 6 to 12 weeks, and it levels off after that. But there is also a higher incidence of nerve injury associated with endoscopic carpal tunnel release, which is why I don't favor that operation. And in terms of outcomes, I mean, this is one of the most successful operations that we do. There's a high 90% success rate when you determine success as symptom improvement. Patients with long-standing numbness and long-standing weakness may never completely get better, although there will be some improvement of what I call the active symptoms of carpal tunnel, such as the burning pains and the paresthesias. Those tend to resolve very quickly after surgery. Most patients at about 6 to 12 weeks after surgery will have their grip strength will be equal to what it was at the time of surgery, and usually after up to about a year it will improve. And sensory symptoms tend to improve for 12 to 18 months after surgery, but never quite equal the opposite side of what it was prior to the onset of the disease. And essentially other complications such as infections or other surgical issues are extremely rare. And in my practice, I find that patients that don't get better after surgery, it's maybe the diagnosis isn't quite right, or there's some other issue going on that needs to be addressed. And then finally, an issue of something such as recurrent carpal tunnel, which is as it goes away and it comes back. Although it is possible, it's very, very rare, and the most common cause of recurrent carpal tunnel is an incomplete release the first time. So clearly I try to make sure that never happens to my patients. So if there's any other questions or anyone has to answer, I'd be happy to field them.
So somebody wants to know if they've previously had surgery for carpal tunnel and they're now having issues with trigger thumb. Can they be related, and can the carpal tunnel come back post-surgery?
That's an excellent question. So trigger thumb, or what it's called trigger fingers in general, called stenosing tenosynovitis. Basically what a trigger finger is it's swelling around the tendons that causes the tendons to catch in the tunnel where the tendons run into the fingers. And basically the common entity here, the common cause here, is the swelling around the tendons. The swelling around the tendons in the carpal tunnel in this area is what increases the pressure on the nerve, and that swelling then continues up into the finger, causing a trigger finger. So I almost daily will see, every time in the office, see someone that has carpal tunnel and then concurrent trigger fingers. And in fact, what's a little bit nuanced about carpal tunnel syndrome is that it does not cause pain in the traditional sense. Nerve pain is different from classic pain. So sharp stabbing pains, if someone describes like severe sharp stabbing pain as their primary complaint, for me that's a trigger finger. And it's often common that most people have them at the same time. Trigger fingers treatment usually is a cortisone injection, possibly followed by surgery if it fails to resolve after several injections. But in generally, the injections do the trick. And in terms of, like I said, recurrent carpal tunnel, it is fairly rare, and most people that develop symptoms later on, once the trigger finger is treated, the symptoms tend to go away. Okay. All right. Well, thank you very much for tuning in. I hope you found this informative, and if you have any concerns, you could please feel free to call our office, and I'm happy to see you for an appointment. This is Dr. Pinsky. Thank you.